My name is Brad Smith. I'm a retina specialist practicing in St. Louis, Missouri in private practice. And our study looked at quantification of eccentric subfields in assessing treatment response for diabetic macular edema patients. And this is a post hoc analysis from the YOSEMITE and RHINE trials. Yeah, so obviously central subfield thickness is the one that's most closely associated with visual acuity, but there's some important anatomical information that can be gleaned by looking at the eccentric subfields. We used to look at those areas more commonly just with slit lamp biomicroscopy to look for areas that we could potentially target for laser delivery. So the idea was to kind of return back to that to see if we could glean information about eccentric subfield response, to see patterns of leakage, to see patterns of resolution, and also possibly use it as another indicator to assess differences between two highly effective drugs. Yeah, so central subfield thickness was obviously involved because that was one of the criterion for being enrolled in these trials. But the intertemporal and the outer temporal subfields were thicker than the other eccentric subfields within the ring, and especially thicker than the nasal subfields. And also the inferior subfields were thicker than the superior subfields. And that's interesting because if you look at a population of diabetic patients with little to no diabetic retinopathy, you'll find the opposite. And that's been shown through some DRCR work. So the Faricimab treatment arms had a little bit of an edge on drying the retina, not only in the CST, which we all know, but also in those eccentric subfields as well, mostly in those temporal subfields. And in fact, it was almost every eccentric subfield where Faricimab had an edge except for the nasal subfields. So when we look at these trials, we often see this sawtooth pattern of just looking at CST where the patient gets a treatment and then the CST comes back up, then they get another treatment, so we have this sawtooth. So the thought is that if we treat a patient to dry their most thickest subfield that was thickest at baseline, we dry that out, we may see a little bit more steadiness in that central subfield so that they do not have this sawtooth pattern and can maintain visual acuity throughout the duration of treatment. Yeah, well, some manufacturers of OCT equipment now have AI-based tools. We see that with geographic atrophy, where they're trying to map out the potential or predictive natural history of geographic atrophy, which is very important. So studies like this, and this is just a small piece of the puzzle, other biomarkers need to be included as well, but we could potentially use it to show a patient what their potential natural history is without treatment to kind of get buy-in to retain them so that they show up for the appointments and get the injections. We could also use it to assess differences in future pharmaceutical trials. When we have highly effective drugs, we can see differences whether or not sustained delivery of medications, like whether it be PDS or TK inhibitors or gene therapy, to see if there's an edge of keeping those eccentric subfields dry as well. So I think we need to validate the findings more. If we're going to look at eccentric subfield drying, we need to define exactly what the normative values are. So that might be different. We do have some prior data that we can draw up on from DRCR, but that might actually be different in individual patients. We have to assess for perfusion abnormalities where a thin retina at baseline is not actually a good thing. And some patients may, because of age, sex, volumetric status, kidney dysfunction, they may have thicker retinas at baseline already. That doesn't necessarily indicate a pathologic process. So we're still a little bit of ways from being able to apply it clinically for the individual patient. So I think also looking at eccentric subfield responses may, if we can with AI tools, help predict what a treatment burden may be for that individual patient once we define that goal. If we define normal as being X amount of microns of thickness or nanoliters of fluid, we might through AI be able to suggest to the patient an appropriate amount of injections to get there. Of course, it won't be 100%, but that is a common question we get from patients these days is, how many more injections will I need? So this may help us answer that. If I'm treating and I'm looking more, paying more attention to eccentric subfields, I might look at what the patient's most thickest subfield is at baseline, and then choose to treat not just until the central subfield has normalized, but until that eccentric subfield has normalized before extending that interval.